Good morning, our district governor. Good morning, past district governors and facilitators and fellow Rotarians on this beat this morning. We want to welcome you to today's online seminar. We want to especially thank those of us that joined quite early, like Rotarians Fred Jewere and our big Egbon, Uncle Tunde Zeche, and other fellow Rotarians that joined quite early. We have about 41 participants now. I think we should start so that at least we'll be able to finish on time. And I want to especially thank our past district governor, Adeniji Raji, who is far away in the United States. I know it's about 3 a.m. or 4 a.m. now for waking up so early or staying late to facilitate today's program. We thank you so much, sir. We appreciate you. We appreciate your service to humanity always. Today's program will be on center on the theme for July for Rotary International, which is on maternal and child health. And we've deliberately picked 2 speakers who, apart from being experienced in these areas, are also running some programs that they will talk more about on maternal and child health, and of course on the malaria prevention in children. And for Rotarians, and especially our current president, this is an opportunity for you to tap from the wealth of knowledge and share same with your fellow Rotarians in your various clubs as you navigate the Rotary year for this Rotary year that we've been asked to unite for good in our services to humanity. Without wasting much of your time, I would like to invite and call on our district governor, Rotarian Lanre Adedoyin, to please give his opening remarks and call this online seminar to order. Over to you, sir, my district governor.
Good morning, my district learning facilitator and fellow Rotarians. I especially recognize our referred past district governors who are our facilitators for today. I thank you all, sirs, for attending this very important presentation. I also thank other district leaders who are here. I can see the district governor nominee online and other district leaders, as well as fellow Rotarians. The importance of maternal and child health cannot be overemphasized. We are in the month of maternal and child health, and thankfully, we have the experts who are skilled and knowledgeable in that area, giving us their presentation on how to improve that important area of focus. I welcome you all to this online meeting and urge you to listen to them attentively so that we can learn from them and build up on the successes that would have been presented to us in the course of this online learning training. So, good morning again, fellow Rotarians, and welcome as we listen to our leaders. Thank you all.
Thank you. Thank you so much, our district governor. Our deputy district learning facilitator, district governor nominee, Uyi Sowobi, over to you, man. Uyi. Oh, see. DGND Uyi Sowobi. Okay.
We're having problem with this network.
Okay, well, I'll take it up from there. Fellow Rotarians, good morning once again. We have Oh, are you there now? Uyi.
Yes, sir.
Okay, over to you.
Okay.
That's left again. I think she has a network problem, sir. You can go ahead, sir.
Okay.
I think so.
Okay. This morning we'll have two topics to look at. The first one,
now.
you are back. Okay, over to you. Over to you. Please go on.
Okay. Thank you very much. Sorry for that. I pressed wrong button. Sorry. My district governor, my revered powerful PDGs, I greet you especially this morning. And I want to thank you for honoring us with your presence and your knowledge, which we're going to tap from. So, fellow Rotarians, this morning we have in the house past district governor Adeniji Raji. Is the past district governor who served districts in 1997, 1998 Rotary year. He is from the Rotary Club of Bagada. He was recently Rotary Action Group for Reproductive, Maternal and Child Health. And so we are honored today to have him speak to us on the topic maternal care and child mortality reduction, the potential of Rotary. After him, we'll also listen to past District Governor Dele Balogun. He served as District Governor 2014-2015 Rotary year. He is currently the country lead Rotary Health Communities Challenge in Nigeria, Rotary Foundation funded initiative. And so we are honored indeed this morning to have these two gentlemen in the house. We'll first, PDG Balogun will speak to us on Rotary Healthy Communities Challenge, malaria prevention in children. So we'll first of all listen to PDG Raji. Please take notes. At the end of the two speakers, at the end when they have spoken to us, we'll be given privilege to make comments and ask questions. So we invite now PDG Raji to speak to us. Take the floor, sir.
Okay. The district governor, Lanre Adedoyin, the training facilitator, learning facilitator, the district learning facilitator, Kola, past district governors here present, fellow Rotarians. Good morning. I guess everybody is in the morning session now. Good morning. As people of action, we believe that no mother should die giving life, nor should a child lose the opportunity of growing. Today, in our communities and around our country, maternal and child mortality and morbidity are at unthinkable high level, but these are preventable. So today, we want to look at the challenges and use our commitment as Rotarians to address the solutions. As you can see on the slide, the urgency of maternal and child health is key. In our country today, the MMS, the maternal mortality rate, is at 800 per 100,000 live births. That means that if you have 100,000 women who gave birth, 800 of them will die. Similarly, for children, we have up to 61 children per 1,000 live births. It also means that when you have 1,000 live births, 61 children will die. And today, generally around the world, over 5 million children die under age 5. And the maternal mortality ratio is about 94%, but that's for the entire world. Before I look at the problems, I would like to share with you some other life-threatening or lifestyles that also contribute to maternal and child mortality and morbidity. I call them lifestyles because people get pregnant when it's too early. We call it too early. When a child of 13, 14, 15 have children, they pose problems of mortality, even morbidity, even illness to themselves. We know when children have 13-year-old get pregnant, sometimes they have VVF, which is also contribute to maternal mortality. The second one is too late. When a woman has a child for too late in her life, doctors say the optimum time is 35, but we can stretch to maybe 40, 45. I'm not an expert in that. But when mothers have children too late in their lives, they also in a way contribute to mortality, maternal mortality, and even child mortality. The third one is too close. Many of you may recall that RMCH started this program with what we call child spacing, where we train women to space their children. You don't have a child this year and next year you have another one, another one. We advise that you space your children at least minimum of 2 years to allow them to be strong and you also to recover from the rigors of labor and childbearing. Of course, the last one is too many. When mothers have too many children, they create risk for maternal mortality because many children also give rise to postpartum hemorrhage, that is bleeding after childbirth. So those 4 areas are risk areas that also contribute to maternal and child mortality. Of course, there are also the 3 T's, which we call 3 T's. First is when a woman is in labor at home, the time it takes for her to decide, or for the family to decide, yes, we want to take her to the hospital, also add to the conditions that can create mortality or even morbidity. That's number one, the time it takes from in the house to decide to take to the hospital. The second is the time it takes from the house to the hospital. Many times our roads are bad. The distances sometimes to the health centers are long, and many times it's over water, in which case that may also contribute to maternal mortality. And of course, the last one is when the pregnant woman is now in the hospital, what time does it take for the hospital to address the case? Is there a bed? Is the theater ready in case it's a cesarean surgery? So those are those little things, even though they look minor, they are very contributory to the maternal and child mortality. Then let me come back to the slide. The slide are put into two areas, but many of them are interrelated. First, one of the most, one of the causes of maternal mortality is hemorrhage, postpartum hemorrhage. That is, after a woman has given birth, the excessive bleeding that occurs is called postpartum hemorrhage, and it can lead to maternal death. Well, doctors say the reason for this is after the baby has come out, after the placenta, I think I'll pause here. I'm sure everybody understands the anatomy of women, particularly with regard to having children, from the placenta to the umbilical cord to the fetus itself, which is in the uterus, which we call womb, and then to the cervix and to the vagina. You know, those areas will be mentioned constantly. So when the placenta has come out and the uterus did not contract back to close the blood, it's possible that the candidates may have excess blood. The doctors say if it's over 500 mil or for vaginal birth or 1,000 mil uh, for the surgical birth, it becomes a big problem and it will lead to death. The other one is the infection. This infection includes sepsis and other infections, which it could be viral infection, and this also a cause for maternal mortality. The third one is eclampsia. Eclampsia. Usually we advise pregnant women to attend antenatal clinics because during the checks, they know whether a pregnant woman has high blood pressure, which is hypertension, or has protein in his in her blood, in her urine. If she's hypertensive and has urine protein in her urine, then she could be a candidate for eclampsia. But if it doesn't take care of it, progressively it becomes eclampsia, which is fits. And sometimes women with those fits run into coma and can lead to death. So it is important for pregnant women to take the antenatal clinics. And there I will also talk about malaria, which is because malaria has great, even though it's on the children's side, has great influence, has great effects on pregnant women. Because if a woman has malaria, well, he has low blood. It will also give birth to low weight baby. It can also give birth to preterm babies. And it's also for her a danger sign for mortality. So that is very key. We will also talk about malaria in the other areas, but those are areas where eclampsia also fits in. Unsafe abortion, of course, everybody knows that many young people will get pregnant, either go to a chemist and procure some medication, or drink a whole bottle of brandy to see that the fetus will come down. But in doing so, they injure other organs of their body, and resultant death is possible. And the last part is obstructed labor. Obstructed labor accounts for about 36% of maternal death, which is either the baby comes across, or some babies with maybe extra big heads couldn't come through the canal, and the mother may labor for too long, and that could cause a lot of maternal death. Going back to the child mortality area, one of the greatest issues for our country today is malnutrition. In fact, Nigeria is the second highest in terms of stunted children in the world. We have 32% of our children are stunted. That is that their height is not commensurate with their age. We also have wasted children, in which case their height is also not commensurate with their weight. So, and this malnutrition stems from not having good nutrients, both for the mother and for the children. When I come to tell you about a few of the programs we are doing, we'll show you how we address malnutrition, how we detect them, and how we treat malnourished children. Of course, pneumonia, diarrhea are all due to poor sanitation. Pneumonia could be viral or fungal, but it starts with coughing and is very risky for children. In fact, most children die of pneumonia, maybe because mothers don't detect them in time. So when a child starts to cough, and sometimes with a phlegm and all that, you know, it has pneumonia, and the best is to quickly take such a child to the hospital. Of course, malaria is our greatest problem. We are the leader of, in terms of the maternal death body in Africa. So malaria is quite prevalent. We know how malaria is it's obtained. That's when you are bitten by female Anopheles mosquito, and sucks your blood and then passes on to other people. But malaria is preventable because there are quite a number of things that we could do. But for mothers, we usually, doctors would normally give them IPT, intermittent preventive treatment, after the first trimester, to ensure that the mothers don't have malaria, which they could also pass to the fetus. So that's one of the areas where malaria is much easier to deal with. We also give mosquito nets, particularly we need to counsel them because how to use the mosquito nets. But most importantly is that we must understand that more than 50% of births in Nigeria are done through traditional birth attendants, churches, mosques, babalawos, and all that. So that creates a problem. State governments have tried to train these traditional birth attendants to know the danger signs when they know that they no longer can handle the problem, to quickly take them to the hospital. When I get to what we do, I will show you the kind of relationship we try to build between the traditional birth attendants and the primary health centers. Of course, preterm complications, malaria can cause a mother to have preterm births, and preterm complications sometimes leads to cerebral palsy or autism, because cerebral palsy results from blood getting to the head of the child, to the brain of the child, and when he's born, he has cerebral palsy. Whereas in case of autism, is due to the fact that the mother at the time of pregnancy has diabetes, and maybe if not treated, the child is likely to be autistic when he's born. Sometimes they have ear or hearing or seeing problems, and many times also they have cognitive impairment. Next, please. Okay, sorry. Birth asphyxia. Birth asphyxia is loss of oxygen. When a child is born and doesn't have oxygen, the breathing is very low, and it will lead to perinatal mortality. Usually, there's a group in Federal Ministry of Federal Medical Center in Abeokuta and UCH Ibadan, or what they call themselves HBB, Help Baby Breathe. They now teach doctors and nurses techniques to use for birth asphyxia when baby doesn't have enough, doesn't breathe well, what they need to do. But that's also a sure cause for perinatal mortality. Of course, poor sanitation is for pneumonia, malaria, diarrhea. Those are things that will cause them. So this slide just to show you that we globally we have made impact. Of course, polio eradication is a proof of our impact. And we can also make impact through global grants. As I said, we are currently executing a $408,000 global grant. And also, we're doing training for health workers, and we are upgrading clinics, providing medication, drugs for the clinics, both for mothers and for children. Of course, we also have partnership with WHO, UNICEF, but there's nothing preventing us from having partnerships with companies in our own environment. Next slide, please. Yeah, why do we think Rotary can take charge? Because we are 200 countries of the world, so we have expertise from all over the world. And even within our own district, we have 78 clubs. So if 78 clubs will do some little projects dealing with maternal and child health, I think we will make an impact. Next slide. Okay. Even though I put 5 here, I have about 14 areas where Rotarians can actually help to reduce mortality. Antenatal and postnatal clinics, it's not just that, because many of those clinics are not equipped for instance, the rapid diagnostic test for malaria. Many times you don't find, so a club can decide to just supply diagnostic tests for the clinics, or go there, because to obtain a global grant, you need to do a community needs assessment. So you could go to many of these clinics and find out what they need. Maybe they need a borehole to have clean water for sanitation. Maybe they need some medication, some test kits. For instance, we supply test kits for malaria. We also supply more tips for testing children for malnutrition. And we supply nutrients. We supply about 8 million naira worth of nutrients to Lagos, 6 million to Ogun State, and about another 8 million to Oyo State. Training of birth attendants. This is key. Apart from the primary health center nurses and doctors, the traditional birth attendants, as I said, play a key role in maternal and child health in our country. So we have to find a way of collaborating with the states or the local government to train them, at least train them to know when there are danger signs and when they should move the candidate or the pregnant woman to the primary health center or to the general hospital. Community awareness. Community dialogue is key to informing the public of the dangers of taking certain actions, like the 4 areas we have said, too early, too soon, and all that, and also to tell them what to do, how to go and register at the next primary health center, and if they are attending the community traditional attendance clinics, that they need to take the IPT, the intermittent preventive treatment. This medication prevents, after the first trimester, it prevents them from having malaria and from passing the malaria on to their children. Of course, nutrition and clean water is also an area you can purchase nutrients. There are manufacturers in Jos, as in Abeokuta, in Ibadan. The Oni and Son Hospital produces some nutrients, even though they are not good enough for severely malnourished children. In our project, we have selected 100 children, severely malnourished children from each state, from Lagos, Ogun, and we have provided these nutrients for them for 8 weeks, and we will measure their progress for the 8 weeks. At the end of 8 weeks, we expect that they will be very fine, and they will just need to take normal food. Besides that, we also do food training, food demonstration, in which case we demonstrate the type of food that mothers can prepare with using our own local food materials that are nourishing for their children and for themselves. Of course, clean water is key to avoiding some of the childhood diseases, diarrhea, cholera, and all those. So you could also decide to go and do a borehole after your initial community needs assessment, do a whole borehole for a clinic or for a hospital. Of course, emergency transport is a big problem. In Ogun State, they have assigned some keke napep to some areas with phone numbers where pregnant women can quickly call and they can take them to the hospitals. Okay, what have we done? Like I said, we have a global grant. Excuse me, we have a global grant. Well, it's tackling malaria and malnutrition in pregnant women and infants. But prior to that, we have done reducing maternal and child mortality in Lagos, Ogun, and Oyo State, which primarily was for capacity building. We trained doctors, nurses, and also did family planning. Family planning is also key to reducing maternal and child health because many people get pregnant uh, without knowing, or they know, but particularly men are not too cooperative in this area. So you could just take a family planning campaign and supply of commodities, condoms, and there are new techniques for long-term preventive contraceptives. These are areas you can take up. During our first year, we have reduced, we found we took 5 hospitals from each state. We found that we have reduced maternal mortality by almost 25% in some areas. Some are not that high. But also we have expanded the cares, the access to care, because it's after our project that Ogun State procure those motorcycles, keke napep, and place them in the low-income areas, areas which are far from primary health centers, to ensure that when a pregnant woman is in labor, he can have someone to call and can be taken to the hospital. Of course, our goal is to have improved outcomes, less maternal deaths, less perinatal deaths. Those are the outcomes. Of course, every project must have a monitoring and evaluation. So at the end of the day, you have to see that, okay, our project has reduced maternal and child deaths. We have also trained workers, because training of uh, health workers is also key, because there are new techniques, there are new ways of doing things. And it's also a motivation for workers when they come for those training, because sometimes we have group discussions and it helps them to go back to their clinics or to their positions and do much better. In terms of the key group in this issue is the community, the community health extension workers who do the testing for malaria, who give them medicine, who do the testing for malnutrition using the M.O.R.E tape, and give them, if they are positive, for instance, for malaria, they give them the appropriate medication. So those people are very important, and they also go to houses to ensure that the mosquito nets that have been given are used, and also to see that sanitation is maintained within the area, even though the local government has responsibility for this. You can have an indicator dashboard where you know, okay, when we come to this primary health center, the number of malaria cases were this, and by the time we finished, we have reduced it. So we can make it happen by using our global or district grants. I've told you the conditionalities for global grants. You must do a needs assessments first before you can go ahead to apply. Also, we can also cooperate. Of course, many of the interventions cannot be done without the cooperation with government and the local government areas, because they hold the key to the staff that we use, and the access to those staff is important. Of course, NGO partnerships, these are things we have not done much in our district, where we use other people who are either into the same area of activity, or they have the resources to help us. Of course, we should also mobilize volunteers. It's only in Nigeria we don't have a lot of volunteers. In Zambia, all the community health workers are volunteers. They are not paid staff like in Nigeria. So what can you do as a club? You can adopt a clinic or an LGA and do all manners of maternal and child health program within that LGA. You can sponsor maternal kits. For traditional birth attendants, we normally give them birthing kits. It's a form of mats where when they go to have their baby at home, they can put it on the floor, and they also have a small knife to cut the umbilical cord. So such kits you can buy and give to them. Of course, training of community extension workers is key. You can just take as a project and train extension workers. Advocacy is key. Of course, people will see how advocacy had worked in polio. So we need to advocate with governments. You're probably aware that the WHO has just published new guidelines for adolescent pregnancies. And one of the recommendations is that Rotarians should make advocacy to their law, to the national assemblies, to promulgate a decree to abolish child marriage. That a girl should not be married not until he's 18. So these are things we can do. But besides that, we can also ask government to increase the budget for health, because that's also where some problems lie. So advocacy for budgets increase, also for training of their staff. Well, my closing thoughts are: saving the life of a mother is saving the future of her family, her community, and our nation. And Rotary has done it before. We can do it again. The time to act is now. I thank you.
Thank you very much, sir. Thank you. I hope we have taken notes, and wow, we have full capacity. 100 participants. That's interesting. So I hope we have taken notes. We'll quickly take the next speaker. At the end of the next speaker, we'll invite us to ask our questions and also make comments. So the next speaker is our past district governor, Dele Balogun.
Good morning, all.
Rotary Club of Agege, District 9111. He's going to speak to us on the topic, Rotary Health Communities Challenge malaria prevention in children. He is currently the country lead Rotary Healthy Communities Challenge in Nigeria, the Rotary Foundation funded initiative. So, distinguished Rotarians, we welcome PDG Dr. Balogun to take the stand. Thank you, sir.
Good morning, all. Good morning, Uyi. Thank you.
Good morning, sir. Thank you, morning, sir.
Good morning, my district governor, Lanre, District
Good morning, sir. Good morning, sir.
912. And good morning, past district governor, Raji. I must thank you for a very well scripted presentation. And thanks for the experience over the years. We appreciate you. You have made my job a bit easier. And I sincerely hope I will have the luxury of time to be able to put my presentation across. The Rotary Healthy Communities Challenge is a new project of the Rotary Foundation. And a donor has been kind enough to put some money together and donated it to the foundation. He has also given terms to how this money will be used such that children will not die unnecessarily from preventable diseases like malaria, pneumonia, and diarrhea. This project started 9 months ago, and it will be on for 3 years. This new program builds on the success of previous Rotary member-led, evidence-based programs that have already demonstrated success, like the polio eradication and like the RMCH too. These are all Rotary-led programs that have been very successful. This project is relatively very young, and this is the first time Rotary is embarking on a project like this. So after the 3 years, I do believe a lot of the problems that we have encountered will be looked into and probably the scheme modified to yield better results. Can we have the next slide? This program is on in 4 countries. Nigeria is just one of them. But there's something peculiar about Nigeria. We have second to the largest number of reported cases of malaria in the world. Likewise, too, we are responsible for 30% of the deaths due to malaria in children under 5 in the whole world. So this is a
Something's happening.
What's going on?
at the end of the 3 years, we have increased access to malaria treatment.
Maybe you should move away from where you are. Maybe it will be better.
We've lost him.
I think you should move away from where he is. Maybe that will improve or you can take off his video.
Yes, and talk. Yeah.
Yeah, and just talk on the slides.
Let me see what I can get him. Oh, that's serious. Just fellow Rotarians, just give us some time to solve the technical hitch. Sure. Wow.
Can you call him?
Yes, I'm trying to do that, sir. He's trying to reconnect again, sir.
Okay.
So, fellow Rotarians, just give us a few seconds for him to reconnect.
Can you hear me now?
Yes, please go on, sir. Go on, sir.
Happy to be back. I lost
sir.
contact.
Yeah.
This is a relatively very new project. And right now, we have scaled through meeting with the stakeholders at the national level. We have scaled through choosing the states where the pilot project will take place. We are working with the government agencies, National Malaria Eradication Program, and the Primary Healthcare Development Agency at the national and at the state level. And we are working in Kebbi State and Akwa Ibom State. These are two states that have challenges. In the north, Kebbi State has the worst cases of severe malaria and deaths as a result of malaria. This is particularly peculiar in the sense that in Kebbi State, you have a lot of rice plantations. And you know, rice is grown in wetlands. So you have static ponds where malaria breeds, mosquito breeds, and it is a big problem in Kebbi State. In Akwa Ibom State has challenges in the sense that it did very well in the past, but in the last 2-3 years, the progress has stalled, and they are now having very bad cases, severe cases of severe malaria and deaths as a result of malaria. So in the southern part of Nigeria, Akwa Ibom has been chosen. In these two states, we have been working with the state primary health care agencies and the state malaria eradication, the Ministry of Health, Ministry of Local Government Affairs. We've been working with Ministry of Women Affairs. And we have assisted in retraining community health promoters, community health, they call them chiefs, community health.
Money, young lady.
So
I want to get the time back.
we gradually have made it possible to follow the government program. Unfortunately, the government at the national level is changing the program. They are no more using tools. In their wisdom, they want to use
Money.
community health inspectors.
My DGE, mute yourself, sir. Thank you.
Chiefs will be able to do a lot of work, unlike in the past, where community health workers were trained for specific diseases. Now we have a broader program where a community health promoter, community health influencers can handle a lot of more diseases. It's no more in vogue that we should just have community health workers working primarily on maternal and child health or working primarily on malaria. Now they are being trained to take on a lot of other projects so that in each of the communities in these two states, we have mapped houses assigned to community health influencers and promoters who have been previously trained, now retrained by Rotary, and who will visit each of these houses on a regular basis. They are volunteers, yes. The government is paying them stipends, yes. But these are people who have been selected by their communities. They have been trained. They have been trained by trainers provided by the government. These trainers have also been retrained by Rotary. So it's very important that we are using these promoters and influencers who have been nominated by the communities. This particular program is a 3-year program. The funding is by Rotary International and Gates Foundation. The coordinators are National Malaria Elimination Program and National Primary Healthcare Development Agency. The same agencies are also at the state level, and we have key partners. Some of these key partners include ALMA. ALMA is an African initiative put together by the presidents of 34 African countries, and they have been assisting in ensuring that we have community-based data collection system. We've had training sessions, 3 training sessions by ALMA, and at the end of the day, we will have the communities assessing our activities, taking ownership, and assisting in the success of this scheme. Unfortunately, the government program is still at its developmental stages. It hasn't been launched officially, but the government has cooperated with Rotary. And we are using this scheme to train, retrain health providers at the community level. We are also training and retraining the doctors and nurses and the community extension workers at the primary health center so that they can cope with the surge that will be as a result of the visits to these homes. Children will be tested, and those that are test positive for malaria will be treated free of charge. Children will be tested for malnutrition, and they will be advised on how best to feed their children, and they will be referred to the primary health care centers. It is also important that all pregnant women that will be met in these houses will be sent to the primary health care centers to register, even if they are going to deliver at the traditional birth attendant facility. They will be attended to at the primary health care centers so that they can have their immunizations, they can have their health education, and if there are complications, they can be referred to the health centers. It is a new project, and we have done the training of trainers. We have done the training of community health influencers and promoters, and hopefully by the end of July, this project will be launched at the states, Akwa Ibom and Kebbi State. These are the pilot states that we are starting with, and we look forward to the active participation of Rotarians in this scheme. A lot of Rotarians are worried that their districts are not actively involved yet. But the truth is, Rotarians are very useful, and they can take on using their global grants, using their district grants, especially the district grants, in doing small projects within their community, which can assist in reducing deaths in children as a result of these preventable and treatable diseases. For example, let us take a Rotary Club in Osogbo, for example, can work with the primary health care centers in Osogbo to educate the people at antenatal clinics, to educate the people at infant welfare clinics, and to ensure that the health inspectors are retrained and put back into the community to ensure that breeding sites of mosquitoes are taken care of. Static water are prevented in the environment, the landlords educated, and the environment kept clean like it used to be many years ago. We still have these community health inspectors, but they now sit in offices. They should actually be in the communities, ensuring that the breeding sites of mosquitoes are well taken care of. We should also ensure that education is provided at the Community Development Association so that landlords can assist in improving the drive towards sending pregnant women to antenatal clinics and towards ensuring that the children in their households attend infant welfare clinics and they are adequately immunized. This project started last year, 2024, and our timeline is now being shown on the screen. October last year, the project was launched, and we had meeting with stakeholders. October, December, there was initial programs set up, staffing, and a lot of meetings between Rotary and our implementing partners. Our implementing partner is PART. That is the organization that is doing the technical work, that is responsible for training and retraining of the trainers, that is responsible for training the community health influencers, community health promoters, and in mapping the houses where these community chosen workers will cover. In the year 2025, we've had consensus building, training of trainers, selection and screening of community health inspectors and influencers. We have also started training these community health inspectors, and we have done mapping of the environment where these chiefs will work. We look forward to actively going from house to house later this month and in August. This is a very new project, and every Rotary Club has a chance of being actively involved, whether you are in the pilot scheme or not. We have environment, we have primary health care centers, we can provide test kits for malaria, we can provide health education to the pregnant mothers, we can provide health education to the mothers at infant welfare clinic. We can even go into the environment and ensure that the environment is cleaner. We have access to district grants. We also have access to small malaria grants. These are international grants, and they don't really require a lot from you. You have to join the Rotarians Against Malaria Global and apply for these small-scale grants that will provide at least $2,500 to your club to carry out malaria reduction activities. About 8 clubs in the whole of Nigeria have started using this facility. There is no club from District 9112, to the best of my knowledge, that has availed itself of this grant. It's called Small Scale Malaria Grant, but in District 9111, Rotary Club of Omole Golden has started using this facility. It is easy for you to apply for this project, this small scale grant, and I will advise that as many clubs as possible can apply for it. You can go ahead and add your money to it, but if you don't have money to add to it, the $2,500 is good enough for small projects. All clubs that are duly qualified for district grants can use part of their grants for this project. It is particularly important that we all, as much as possible, take part in this malaria eradication project. In terms of area of focus, the area of focus in the Rotary Foundation activity is this disease prevention and treatment and maternal and child health. This project will last 3 years. We've done 10 months already, and we are now getting into the community later this month. And it has been funded by Rotary International and the Gates Foundation, and our implementing partner is PATH. We are working by integrating into the existing platforms at federal and state level, and we will scale up based on the successes of what we have done. We hope at the end of the 3 years, we will have more money to be able to work in other states in Nigeria. I must thank District 9112 for giving us an opportunity to talk about the Rotary Healthy Communities Challenge. I sincerely hope there will be questions. Thank you very much.
Thank you very much, my past district governor, Dr. Balogun. That was wonderful. We are still at full capacity. And I thank you, Rotarians, for taking your time to join us. Please, if you have questions, you have comments, let's see your hand at the chat room. I will take it. If you want to write it out, we're on the chat room too. Please do so. Let's hear from our distinguished Rotarians. Rotarian Adedoyin, Emmanuel, please take the floor.
Thank you so much, sir. PDG Dele Balogun. Thank you so much, sir. Good morning, fellow Rotarians. Good morning, my...
Good morning. Good morning. Let's go straight to the point.
I think, okay. All right, I'm from Rotary Club Anthony Golden, District 9112. And I joined in while the first presentation was ongoing. However, it's interesting me to know that we have a Rotary Health Challenge, community health challenge that is focusing on malaria, diarrhea, and the likes. However, my question basically even though I already heard that there are 2 pilot schemes that are going to take place in both Kebbi State and Akwa Ibom State, while there is also a small scale grant project as launched by Rotary. So I wanted to find out what are the requirements for clubs now that we are aware that there is no club yet in District 9112 that's actually enrolled or shown interest. What are the requirements, like what steps need to be taken aside maybe attending the grants seminar, and for this Rotary year 2025-2026, what needed to be done in the immediate such that any club that is interested can actually take advantage of this program? And are there need for maybe voluntary Rotarians from club sides to be trained or to reach out to the district and then get more information as regards this so that they can take it further from there? Thank you.
Thank you very much, Rotarian Adeleye. I think I'll just take your question once and for all. Rotarian Akauma Onyimelukwe of District 9112 is actually in charge of this small scale grant, and you can get in touch with her. She will educate you on what you need to do. Rotarian Akauma Onyimelukwe is from Rotary Club of Bagada. Thank you very much. Can we take on more?
Thank you. Thank you.
May I
Yes?
just add that
Yes, sir.
I am the Nigerian RAM ambassador for Rotarians against malaria. And if you have questions, you can also ask me. But I must also add that the 2,500, you could use it just for community needs assessments. In case you have to travel, you have to go and check the records before you can apply for a global grant. And some of you in Calgary also heard that there's a new malaria fund that you can use for your global grants. Thank you.
Thank you, sir.
Thank you very much, sir. We're still taking questions and comments. We'll invite Dr. Tunde Ezichi to speak, please.
Thank you so very much. PDGs Adeniji, Raji and Dele Balogun. Very, very elucidating presentations by both of you. First question to both of you, can we have access to your presentations? Is it possible to get your presentation slides? That's one. Then secondly, my second question, which perhaps specifically to PDG Dele Balogun. What is the situation? You see, malaria has been ravaging the world for such a long time. Maybe for us in the tropics, it's a good thing we have malaria because it helped us to drive away those slave masters. But why has there never been, what is the situation on getting a malaria vaccine? What is the situation report on that? Thank you.
Thank you very much, my brother, Tunde Ekaro. Yes, the pilot project on malaria vaccines have started in Nigeria, in some states, and is mainly for children. And you have 4 doses, which will be given at the primary health centers. I know Kebbi State is one of the pilot states. I think there's another state.
Bayelsa.
Yeah. Thank you very much, sir. So we are still at the very early phases. Essentially, the vaccines will provide a protection to these children so that they don't have severe malaria cases, especially before they are 5 years old. At the age of 5, most children will have been exposed to malaria and they will have developed some amount of immunity. So these vaccines are meant for children under 5 and is still at the experimental phase in Bayelsa and Kebbi states. Thank you very much, my brother Tunde Izichi.
Thank you very much, sir. We're still taking questions, but we're rounding up soon. We'll take the next question from Rotarian Ebon Ekomobon.
Good morning,
Morning.
presenters. Good morning, the DG and fellow Rotarians. I had two questions, but I think Rotarian Tunde have asked the first one because I'm more particular about the vaccine, which is more preventive than the drugs and the injections that is just to treat. So probably, I think when the vaccine is finally rolled out, I think it will be a better option for us in this course. Then I just want to suggest on the need for us to expand the participants quota above 100 because so many Rotarians couldn't join this discussion because the capping is on 100 participants only. Thank you very much. It's been a wonderful presentation, and I think we've learned a lot. Thank you, Sas.
Thank you very much, Rotarian Ebon. We don't have any more questions and no hands up, so we believe that we are all fine. May I invite my past district governor, Kola Sodipo, to handle the next stage.
Yes, thank you so much. Thank you, my dear fellow Rotarians. I also want to thank our facilitators for this morning session, past District Governor Adeniji Raji, and of course, past DGND Dele Balogun. We appreciate your presentation, and for all our fellow Rotarians that stayed back, we still have over 100, 100 participants still online. We thank you. There was a question by Rotarian Eziche, and of course, you'll get the slides. We'll forward it to you on the different platforms. The presentation slides, both for PDG Raji and PDG Dele Balogun. I want to thank you, and this is going to be a monthly program. But for the DG installation that we had last Saturday, will have been last today's program. We're going to have it first Saturday of every month between 8 hours of 8 a.m. and 9 a.m. Focus on the various themes for the particular month. So next month, which is August, we're going to focus on membership and membership development and new club formation and activities surrounding that. So please mark in your diaries for Saturday in August for that. Without wasting much of your time, I would like to call on our district governor to please give his closing remarks, and then we'll bring the program to a close. District governor, sir. DG.
DG, you have to just
unmute. DG,
unmute.
Can you hear me now?
Yes,
Yes, we can.
Thank you very much, our district learning facilitator. I must particularly thank our two revered past district governors who have enlightened us, educated us, and shared their tremendous wealth of knowledge with us. This session has been particularly impactful. We can't thank you enough, sirs, for what you have done. And I think that the take home for all of us is that we need to do more in our quest to serve humanity. Maternal and child health is of interest to the district too, as well as the other areas of focus. And we are going to work very hard with the various clubs to ensure that we deliver and that the district is the better for it. I want to thank all Rotarians that have participated in this online session and our Deputy Learning Facilitator, DGND Uyi Sowobi. Well done. Thank you for all that you have been doing.
Thank you, sir.
I also recognize my DG, Lanre Adedoyin. Thank you for being part of this. So I want to encourage all of us to continue to participate in this monthly online learning training. It is very, very important for us because Rotary is a knowledge-driven organization. And the more we learn, the better Rotarians we are. Thank you and have a lovely weekend.
Yes, thank you so much, sir. Our district governor, I want to thank all the participants, and I want to wish us well. Do have a wonderful weekend. Don't forget to vote, those of you that are in Lagos State, and those of us in Ogun State will be waiting for your results. That's on a lighter note. Have a nice Saturday morning. Enjoy the rest of the weekend. Thank you, and God bless you all.
Thank you, sir.
Okay, sir.
Bye.
Yes, sir.
Bye.
Good morning, sir.
Thank you, sir.
Hey,
Bye,
DG.
everyone.
Good morning, sir.
Thank you.